via Zoom during the corona crisis of 2020. I'm Dr. Frank Speidel, a retired emergency physician and recovering hospital administrator. Thanks for watching The Doctor Is In, where we explore issues in U.S. healthcare. But first, the disclaimer. For as Shakespeare reminds us, foolery, sir, this walk about the orb like the sun. It shines everywhere. So I invite you to consider my comments with utmost robust skepticism. I am neither an epidemiologist, public health official, nor infectious disease specialist. Always defer to guidance from your primary physician, local health department, or the CDC. As I wrote the introduction for today's show, I note that COVID-19 has claimed the lives of 173,000 Americans. There is no comfort in knowing the Spanish flu claimed around 650,000 Americans in 1918, or that the 1957 and 1968 influenza epidemics took around 100,000 lives. This hideous disease, is there a comforting disease, fulfills the name dis-ease, coming from the Greek prefix dis, meaning evil or foul, as in dystopia, where it's linked with the Greek word for place, topos, as opposed to utopia, the good or well place. With the COVID-19 pandemic, there is massive ill-ease. But I wonder if some of this ill-ease we have not generated ourselves through fear and thought-free actions, in giving our emotions priority over reflection and thought. Have we added more dis to the disease? One of my guests on The Doctor Is In the early months of COVID made an off-camera observation, not for attribution, that we had a witch's brew that would shrivel Macbeth. We had the confluence of an election year and a novel virus pandemic. Those standing for office, he predicted, would assert their toughness in taking on the virus, their willingness to do whatever it takes to defeat the virus to keep voters safe. In the days of COVID, we are told we need people who will take bold actions. Who can argue with that? My guest also offered that while rhetorically be both bold and dynamic, content and specifics will be thin and sparse. And political opponents, well, they would be science deniers, and they wouldn't care about children or those who will sicken and die. Now, I think all sides are guilty of this smooth cortex, cliche-dipped rhetoric, hitting the buttons of fear instead of flipping the switch of illumination and piercing the darkness with light. And throwing gasoline on the briquettes of political pitchment is the media, which has traveled far from H.L. Mencken and Edward Murrow, where once I felt confident that those writing and broadcasting were aspiring to get reporting, both accurate and precise, with perspective and insight, I now see the school of, if it bleeds, it leads, in full gallop. Watch the news. Breathless lurid reporting, intoning on the latest pro athlete to test positive. The breaking news of the increased number of those testing positive. Instead of professionals conveying information, we have shrill carny barkers hustling for clicks and ratings. Beyond the reporting of events, the media floods us with admonition by experts. We need more testing. We must listen to the experts. Science will show the way. And we all need to hold fast together till we have the vaccine. Sadly for me, the media does not explore these mantras of the age of COVID-19. Many of the reported standards, seemingly plucked from the air, are accepted and repeated by the media without question. Equally sad, events of substance and significance may not make a ripple in reporting. On July 21st, 2020, the Pennsylvania Health Department issued a temporary suspension of vaccination requirements for attending school. The rationale was the potential need for school nurses and Department of Public Health nurses to be tasked with pandemic-related mitigation, including the possibility of mass COVID-19 vaccination clinics, may prevent schools and the department from holding catch-up clinics for children's well-child immunizations. I assume that's as opposed to adults' well-child immunizations. Not until August 3rd does the Inquirer report the quietly announced suspension of vaccination requirements by the PA Department of Health. There is no Inquirer editorial on this suspension until August 10th. Now, does anyone else find it noteworthy that the lead agency for the Commonwealth for Health quietly suspends the requirements for existing safe, effective vaccine to preserve resources for a yet to be developed vaccine of yet to be tested safety and efficacy? Is there any concern for the messaging the Department of Health sent? More importantly, is there any concern for the clarity of thought and values of those making these decisions for the citizens of the Commonwealth? And what about reporting insight and perspective in the Inquirer and the rest of our media? One thing we can be certain of is hearing, after the exhortation of the need for more testing from both politicians and the media, is the need to follow the science. Really? The American Academy of Pediatrics issued COVID-19 planning considerations, guidance for school reentry. I note and appreciate the AAP's clarity. The AAP strongly advocates that all policy considerations for the coming school year should start with the goal of having students physically present in school. And they provide perspective. Finally, policymakers should acknowledge that COVID-19 policies are intended to mitigate, not eliminate risk. Their thoughtful analysis assesses and judges risks and benefits. And a fair review of the epidemiology reports from countries that have either reopened or never shut their schools supports the AAP's position. Hearing the discussion and seeing the actions in the public space concerning school reopens leaves no doubt that polling and constituencies, not science, drive these decisions. And one last comment on science, the media, politics, and decisions for the common good. From the July 14, 2020 Lancet Infectious Disease issue, a strong study out of Geneva based on seroprevalence is presented. I find it noteworthy. If you look at the slide that you should be seeing, you'll note that the infected fatality rate, the IFR, from this very well done study for 5 to 9 years is 0.0016%. For 10 to 19, the IFR is 0.0032%. 20 to 49, it is 0.0092. And it is not until you get to the 56 to 64 year range that you get 0.14% IFR. Now bear in mind that the IFR for seasonal influenza was 0.1. So it's not until you get to the 50 to 64 year range does this article report a comparable infective fatality rate. To help me sort out our understanding, to define ways forward in these passionate and conflicting times, I am very honored to have Dr. Richard Lorraine, Medical Director of Montgomery County Health Department, with us today as guest. Dr. Lorraine's service is not limited to the civilian sector. Dr. Lorraine is actually Lieutenant Colonel Lorraine, Commanding Officer of the 193rd Special Ops Medical Group, the Det 1 out of Fort Indiantown Gap, PA. Colonel, thank you for your service and welcome to The Doctor Is In.
Thank you, Frank. It's a pleasure to be here this morning with you.
What did I get wrong in my intro? Feel free.
Well, you put me in kind of a unique circumstance here of having to agree with you on any number of issues that you raised. But let me start off by saying that in at least two of my positions, in addition to the Office of Public Health and the Pennsylvania Air National Guard, I'm also a physician in private practice.
Yes.
And in at least two of those positions, I do not engage in political discussion. So I'm going to bypass that part of your introduction and not make any comment on that part. I'm also going to step fairly gingerly on the second part relating to the media. I will tell you that as part of my duties, I think it's very, very important that I monitor the information that's going out to the public, and I do try to observe the media, both the local and the national media. And I do find myself very often taking notes on things that are misleading, things that are omitted, um, things that I believe are flat out wrong, and occasionally things that they get right. But I'm not going to comment on the media any further than that because I do have to have a relationship with them. There's a whole lot of other things that you raised in your introduction that I think are really, really important things that are not really getting out to people. The study that you quoted, I'm going to kind of go a little bit backwards. The study that you quoted from Lancet, which I haven't had a chance to read yet, and I cannot wait to take a look at that from what you just described, is something that we've been seeing situationally really since the beginning of this COVID pandemic, that the case fatality rate is very, very much dependent on age and comorbid conditions. And this is a real key for us in terms of public health policy. And what that should have identified early on, and I think finally did, is that our focus needs to be protecting our vulnerable populations. So we need to be very, very careful about exposure to the elderly and the infirm. The largest collection of which, the largest concentration of which, of course, are in our long-term care facilities. And that's something that has created considerable difficulty. I can tell you, taking off my public health hat and putting on my military hat, a lot of the Pennsylvania National Guard medical personnel, including myself, have been deployed in assistance programs in long-term care facilities. We've sent in clinical staff to do staffing assists for when they are overcome and or their individual staff is out ill. We currently still have a very, very active testing mission. We're sending out point prevalence testing teams to long care facilities to try to identify COVID infections and to try to cohort them appropriately, thereby trying to decrease the rate of infection transmission. And this also is to help assist with the Secretary of Health's mandate that regular and 100% testing be performed in long-term care facilities. The other thing that's being lost, which you did make reference to in your introduction, and I think it was specifically in referencing the AAP's recommendations, is that we are looking to mitigate risk. We are not looking to eliminate transmission. That is an impossibility. When we started with our shelter in place and our limitations on schools, when everything was shut down, the phrase that you heard was flatten the curve. And that's absolutely correct. This has been a part of pandemic prevention or pandemic response for a long time. That our concern in the case of a pandemic is the overwhelming of our healthcare facilities by critically ill patients, so that we would run out of ICU beds, we'd run out of ventilators, we'd run out of personnel to take care of them. So the idea initially in mitigating this was to decrease not the area under the curve, but the slope of the curve, so that we don't have as quick a development of as many cases, we don't overwhelm facilities, we're able to keep up with it. And we did a fantastic job of that. In some cases, there were surge facilities that were stood up that weren't used hardly at all because we did such a good job with that. But the focus really needs at this point to kind of go back to that, which the AAP references. We need to understand that these mitigation strategies are designed to flatten the curve, to decrease the demand on our healthcare facilities, and secondarily now also to help protect our vulnerable population. it is an absolute impossibility, as I said before, to eliminate the spread of the infection. And that seems to be lost in translation right now. So
thank you very much, Dr. Lorraine, for saying that. I think that is harming us no end. I alluded to the fact that the media allows, somehow there was a translation from mitigation to absolute containment that occurred without any public discussion. No hard questions have ever gone to people who make these decisions. I have yet to see that happen at a press conference. I've yet to see that come out. Absolute containment. We need more testing. There's an article in there's two articles that are out there right now where someone's advocating multiple tests per day for every individual in the United States. To what end? If you would have to know that information instantaneously, perfectly, and have it reported to be able to even affect containment. And between the time you got that information and the orders went out to whoever, it's already spread. Somehow we are become obsessed with containing something that is out of the toothpaste tube.
Yeah, I totally agree with that. We cannot contain this at this point. We can mitigate it and we can work with it. I don't like using comparisons to seasonal influenza all that much because this is a different setting. This is a different virus. There's a different infectivity rate. There's different mortality rates. We do not have a vaccine. We don't have treatments. The treatments for influenza are there. They're not that great, but they are there. So I don't like using the comparison all that much, but every year we do see a rise in influenza during the so-called flu season. Flu is actually present the entire year.
Thank you, it is.
But the peak is during usually the winter months, and probably because of close contact with individuals. So we see a number of flu cases during the winter. We do our best to control that. We do our best to treat it, but we don't shut everything down. We don't look to totally contain it because it's just not possible. So
we are in total agreement on this. And we don't have this wonderful, the AAP did a wonderful job of presenting balance of risk and reward. Every year we lose about 400 young people under the age of 15 to swimming pools, to drownings. Should we get rid of swimming pools? Because I've heard the argument when I talk about this. If we can just save one life by staying shut down, by keeping the schools closed, because we know kids have the disease, if we can just save one life, we need to do that. 9,000 children under the age of 12 are killed in motor vehicle accidents every year. Get rid of cars? Say kids can't ride in cars? We could save lives if we did that. Well, no. The human species, the Greek poet Aeschylus, I think, said man was not made for safe harbors. We're risk takers. That's the way we live our lives. I thank you for sharing this. I wish we would understand we're talking mitigation, not containment. What other public health lessons can we take away from this, Doctor?
Well, one of the things that we came up with within our health department, within the state health department, the Office of Emergency Management, is that we found that our preparations for a pandemic were out of date. So it was out of date both in terms of the procedures and policies and the materials. When the pandemic started and we looked to the National Strategic Stockpile to look for whether it was medication or ventilators or other equipment, unfortunately, what we found is that it really hadn't been updated since the last pandemic, the H1N1, which I believe was in 2009, 2010. And there were a whole lot of things there that were expired, that were past their useful life. So these policies, procedures, and materials had not been regularly reevaluated and upgraded over the years. Again, switching hats. My Air National Guard unit actually is a part of something called the CBRN Task Force, chemical, biologic, radiologic, nuclear. So we are prepared to respond to disasters in any of those areas. So we maintain training on all of those things. And we have checklists where every year there's specific trainings that have to be accomplished to keep up to date. We have a formulary in our medical detachment that the second something is expired is exchanged, and we make sure that that's kept up to date. I have bi-weekly teleconferences which includes all of the full-time staff and our executive management committee. Our logistics NCO is always on top of that. So on the military side, we do pretty well with that. That needs to be translated into the public health sector as well, that we have to maintain that state of perpetual readiness. We can't lurch from one crisis to another crisis. It's expensive, it's time consuming, but it's necessary. The other thing that I think I'm hoping comes out of this is translation, and as we've been referencing, translation from actual experience, actual data into policy and procedure, so that we do things not just to do things, but we do them because they have a reason, they have a basis, they have evidence that support them, and that the outcomes as a result become better. One other thing I just have to touch on, because you came very, very close to an analogy that I use on a regular basis in the office. When we're talking about treatment for medical conditions, and I see someone who might have diabetes or hypertension, and I recommend a medication for them, oftentimes there's concern raised about the side effects of the medications. So the first part of that is something called the risk-benefit ratio analysis. And yet that's what you were alluding to. Everything that we do has potential risk associated with it and potential benefit. We always calculate the ratio of the two, the risk versus the benefit. If the risk outweighs the benefit, we're not going to do it. If the benefit outweighs the risk, it would be a recommended policy. The second part of that, when I try to illustrate in terms that people can understand the concept of acceptable risk, you talked about deaths by motor vehicle. That's exactly the analogy that I use. I asked them, okay, how did you get to my office today? And did you drive a car to get here? Yes. So occasionally I'll get an answer, no, I drove a truck, which I appreciate that when they do that. And I'd say every day in the United States, roughly 200 people die in motor vehicle accidents. Why did you drive a car knowing you could possibly die? And the answer is that you, the patient, looked at the relatively small risk and decided that the benefit was a whole lot more important to be able to get to where you needed to be. And that's what we do. We do things on an individual level and a general level in terms of accepting risk. Some people accept more risk than others. Typical example is skydiving. I'm sure you've heard this phrase before. I personally would never jump out of a perfectly good plane.
Amen. Absolutely. Unless it was on fire and we were really high up.
Of necessity. And then the benefit increases, so the ratio changes.
Absolutely. I want to touch base on something. I looked at your Montgomery school comments about the Montgomery County comments about reopening school. I think you did a great job. Tell us about that.
Well, I personally can't take a lot of credit for it. That was done while I was mostly deployed. So I was available by teleconference and by phone, but that was mostly done by our director of communicable disease and the rest of the department. I agree with you, they did a great job. If you look at the correlation between that and the American Academy of Pediatrics guidelines and recommendations, you see how close they are.
Yes, and which is unlike the Commonwealth of Pennsylvania, has gone a different way that says, well, you may do this.
Mm-hmm.
Gives, that's shedding responsibility. It's like, skipper, should I go right or should I go left? You may go to the port or you may go to the starboard. That's not what leadership's about. By the way, please take credit for it, because there are going to be times, Colonel, when you got the blame for something you weren't responsible for. So enjoy the time, because I thought Montgomery County did a wonderful job there.
Let me also emphasize the American Academy of Pediatrics. If we could just put that on the news and repeat it over and over again, their recommendations, I found them amazingly cogent, rational, science-based. Starting off with the proposition that schools should be open, that students should be in school. Again, when we talk about risk versus benefit, there's a lot of risk for students not being in school. There's a whole lot more to it. There's the decrease in learning, there's the decrease in socialization, there's the social safety net of the meals that are provided. Though the special needs kids are definitely not going to do as well. Even the fact that the kids might not be in school might keep the parents from being able to go back to their job. There's downstream effects too. This can contribute to economic deprivation. There's all kinds of things, and you have to consider that when you look at the potential risk of children not being in school. It's not purely their exposure to this virus.
Colonel, we're going to have to close the show up, but I want to thank you profoundly for a whole bunch of things, for fighting the good fight, for your service both in uniform and in the wonderful swirling world of public health, and also for actually seeing patients and taking care of patients. It doesn't make you a bad person when you see and touch patients regularly. So I thank you. And we're going to put a slide on here if you will have some points of contact for information in Montgomery County to provide to the viewers here. Again, Colonel, I thank you so much. And for the viewers out there, I want to thank you for taking the time to watch The Doctor Is In. Be safe.